Uh, Good evening, ladies and gentlemen. My name is Dr. Raad Osman from Tripoli, Lebanon, and it's my pleasure to serve as the chairperson and moderator of this session. I would like to warmly welcome all of you and thank you for joining us today. I would also like to express our sincere appreciation to Servier for their support in making this education meeting possible and for their commitment to advancing cardiometabolic care and continuing medical education. So before we begin our scientific program, I would like to briefly set the stage by highlighting a few important points regarding the burden of and complexity of cardiometabolic disease. So this is my first slide. This slide summarizes the major real-world acute coronary syndrome registries conducted across the Gulf region over the last 15 years. Together, these registries, including Gulf Race, Gulf Race 2, Gulf Race 3, Gulf Coast, Kuwait Perfusion, SPACE, and STARS, have enrolled more than 64,000 patients with acute coronary syndrome. They provide valuable insights into our population, showing that Gulf patient and region patient tend to present at younger age with more comorbidities, with a high burden of cardiovascular risk factors, more left ventricular dysfunction, and more extensive diffuse coronary artery disease. These data have been essential in understanding a regional pattern of acute coronary syndrome patient and in guiding improvement in preventing and management of acute coronary syndrome. The second slide highlights an important concept. Cardiometabolic disease is rarely a single condition. In fact, multimorbidity is the rule rather than the exception. Worldwide, only about 10% of patients have diabetes alone, 16 patients have diabetes associated with dyslipidemia, and 18% have diabetes with hypertension. More importantly, more than half of patients, about 56%, have all three conditions together: diabetes, hypertension, and dyslipidemia. This overlapping risk factor act synergistically and increasing the cardiovascular risk. Therefore, our approach should move beyond treating isolated disease and focus on comprehensive cardiovascular risk and reduction through integrated management of all cardiometabolic conditions. So this emphasizes why a holistic patient-centered strategy is essential to improve cardiovascular outcome. And the final slide highlights that multimorbidity is not confined to a specific region. As you can see here, it's a global phenomenon. A recent analysis, including more than 120 studies and nearly 15 million adults, found an overall worldwide prevalence of 37.2%. However, there are an important regional difference. The prevalence range between 28% in Africa to nearly 46% in South America, with North America and Europe, as you can see here, showing high rates. So this finding indicates that more than 1 in 3 adults live with multiple chronic conditions, emphasizing the need for integrated and patient-centered care. As population age and cardiometabolic risk factor increase, multimorbidity will become an ever greater challenge and healthcare system worldwide. Therefore, instead of managing disease and in isolation, we need a strategy that addresses the whole cardiometabolic spectrum. Here we can see that we have a new medical e-book, the Cardiometabolic Connect, and this is a very interesting educational platform. You can join by the medical e-book here, and this medical e-book is very interesting, focusing on cardiometabolic disease, providing up to medical information, and connect with experts to ask questions and comments. And you can register now by using this QR code.
Welcome to Medical WeBook on Cardiometabolic Connect, bridging knowledge and care in a truly innovative way. Structured like a traditional book, the platform is divided into chapters and paragraphs. But here's the twist. Each paragraph is brought to life with dynamic, TV-style video content designed to engage and educate. You can add personal notes directly into the content and search them anytime, making your learning truly personalized. Got a question or insight? Use the private messaging system to connect directly with experts. And when you're ready to go deeper, additional resources are just a click away. Medical We Book, where modern learning meets clinical excellence.
So far, we have seen that cardiometabolic disease is characterized by multimorbidity and that this challenge affects millions of patients worldwide. So addressing such complexity requires a multidisciplinary approach. Today's program brings together three distinguished experts who will guide us through different but complementary aspects of cardiometabolic care. We have with us today Dr. Mohammed Zahid will begin discussing hypertension beyond blood pressure control, emphasizing the broader cardiovascular implication of hypertension. Dr. Walid Addahi will then focus on diabetes and metabolic factors, highlighting the interplay between diabetes and cardiometabolic risk. And finally, Dr. Fahad Al-Kindi will address treating multiple morbidity, exploiting practical strategy for management patients with multiple coexisting conditions. Together, this presentation provides us with a comprehensive view of modern cardiometabolic care. It's now my pleasure to invite our first speaker, Dr. Mohammed Zahid. Dr. Mohammed Zahid is the clinical assistant professor in clinical medicine, WCMC Qatar. He worked at Hamad General Hospital, Hamad Medical Corporation, Qatar. The floor is yours, Dr. Mohammed.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and good evening all. I hope and pray that you all are in the best of health where you are joining me from. And thanks to the Servier team for inviting me to participate in this webinar. The topic today is to give you an update on hypertension, and not only on hypertension, but beyond the control of hypertension. So in the next 20 minutes or so, I will try to cover the magnitude of the disease, and then I will briefly summarize the AHA 2025 guidelines. Then we'll go back to the basics, understand the physiology so that we can understand the pathology, and then apply that knowledge in one of the major antihypertensive medication, which is the ACE inhibitors, and then look at the evidence in favor of that. So hypertension, as they call it, it's a silent killer. And the data I'm going to present is the WHO 2024 collection. So in 2024, an estimated 1.4 billion people are affected with hypertension. And more importantly, that every second of every day, more than 1 million people face, and I emphasize on that word, which is the avoidable risk of heart attack, stroke, and death. And avoidable means that we can avoid it if we properly control and treat hypertension. Despite best efforts, we are still struggling to diagnose and treat. And we are no different from the rest of the world. This is the data from the local Middle East. In Qatar, where I am based now, about 40% of the population have got hypertension. And we know that hypertension is the number one risk factor for the major killer. The number one killer is cardiovascular related deaths and the stroke, and hypertension is the number one risk factor related to these two diseases. There are direct and indirect. This hypertension is related to 10.4 million deaths per year. And every 20 to 10 millimeter of mercury rise in blood pressure doubles the risk of cardiovascular disease across the entire blood pressure range, starting from 150 by 75. What does that mean? I'll come to that in detail. So we know that about 40% of the patients who have got hypertension remain undiagnosed. Nearly another 40% who are diagnosed and treated, their control remain poor, and about only 20% are those who are treated and they have got good control as well. So looking at it, about 80% of the patients with hypertension are either undiagnosed or treated, but the control is not achieved. And why it is so? If we look into it, the major reasons are, as we know, number one, it's a silent killer. Because it has got no symptoms to start with, so it remains undiagnosed. Two, that those who are diagnosed, the compliance remains very poor. And linked to that is, if we want to give them too many tablets, they will not take all of them. And don't and one other important bit is the physician inertia as well. We don't go up on the ladder as well to control the blood pressure. So if you look at the 2025 AHA guidelines, there is a slight difference there, So the normal range is now less than 120/80. Between 120 to 130 systolic is the elevated blood pressure. And up from 130 to 140, it is stage 1. And as we go up, stage 2 and stage 3. So the normal blood pressure is less than 120, while between 120 to 130 is the elevated one. So ideally, we would like the blood pressure to be less than 120. And with the new AHA guidelines, the threshold to start the treatment is slightly different. So I'll allude on that. It's slightly different from the European guidelines, where they say the elevated blood pressure is between 120 to 140, and the grade 1 is 140 and above. So if your patient have got a blood pressure of more than 140/90, you need to initiate them on antihypertensives. And majority of such patients will need dual medications to control their blood pressure. If your patient have got blood pressure above 130/80 and they have got an established cardiovascular disease, we need to start them on antihypertensives and bring their blood pressure below 130, ideally below 120. If they don't have an established cardiovascular disease but have got risk factor, again, we need to start antihypertensives if their blood pressure is above 130/80. And lastly, if their blood pressure is persistently above 130/80 and they have got no risk factors, and we have advised them the lifestyle modifications, but despite that blood pressure remains above 130/80, these patients also need antihypertensives. So what are the antihypertensives? We can use the main is AC inhibitors or ARBs, thiazide-like diuretics, and long-acting calcium channel blockers. So for stage 1 hypertension, which is blood pressure above 140/90, you need to start them, above 130/80, you need to start them on single antiplatelet. But if their blood pressure is more than 140, majority, I will say, will need double antihypertensives, and more importantly, in a combination pill to increase the compliance. And if their blood pressure is more than that, then we need triple therapy and more medications. And that part is beyond today's talk. I emphasize again that majority of our patients who needs dual antihypertensives needs a combination tablet, because a single tablet and 2 medications in it to improve the compliance. Pretty much same by the European Society of Cardiology as well. So they also emphasize almost same, that we need to start the medications in a single pill. If the blood pressure is persistently above 140/90, we need to give them a single tablet, double antihypertensives. And if the blood pressure remains uncontrolled, we need to move up the ladder with triple therapy. I just want to emphasize once more that physician inertia is also a big factor in that we are unable to control the blood pressure. So I alluded to that, and I just want to make one more emphasis here, that we don't have to forget the lifestyle modifications. And I'm sure my colleagues who are going to talk on more on diabetes and metabolism, they will emphasize on that. We all, number one, need to, whenever we are following up the patient, need to emphasize the lifestyle modification, which is they need to quit smoking, healthy lifestyle, diet, weight loss, and all that, which will not only improve their blood pressure, but overall they will get plenty of benefits regarding the metabolic diseases. Okay. And going back to basics. So if we look at the cardiovascular disease spectrum, the blood vessel lining, the inner lining is by a single layer, which is called endothelial lining. And normal endothelium produces nitric oxide, which keeps the vessels dilated, maintain the distensibility of blood of the vessels, and we maintain our blood pressure. When we have got risk factors like smoking, dyslipidemia, insulin resistance, and hypertension is one of the major risk factors, it leads to endothelial dysfunction. And what I mean by endothelial dysfunction is that the nitric oxide production goes down. And nitric oxide, what it does in the body is that it is, number one, it's a vasodilator, so we don't get vasodilatation. And it is an anti-inflammatory and anti-thrombotic agent as well. So when the nitric oxide production goes down, there is a persistent endothelial injury which is going on. It allows the LDL, the low density lipoproteins, to seep inside the intimal layer, and it gets oxidized. The oxidized LDL is then produces the adhesion molecules, which leads to then foam cell formation and atherosclerosis. Once we have got atherosclerosis, the arteries become stiff, they are less distensible, and this goes to a vicious circle in which we will have got hypertension and related morbidity and mortality. So the risk factors lead to endothelial dysfunction that promotes atheroma formation and thrombosis, leading to cardiovascular deaths and morbidity. Second concept which we need to understand is the arterial stiffness. Normally, when the heart contracts, the arteries have got a feature which is that they're distensible, they're compliant to that pressure. But if the endothelial damage is there, which led to atherosclerosis, arteries become more and more stiff. As the heart contracts, the pressure wave moves forward, and that pressure is transmitted to the microcirculation, which leads to nephropathy, small vessel disease in stroke, in strokes. And this pressure reaches to the heart way earlier than it should be. Normally, it reaches to the heart in diasystole and improves the coronary flow. But in arterial stiffness, because the pressure rises very quickly, it reaches back to the heart in late systole, leading to, for the heart to work and pump more and more, leading to left ventricular hypertrophy to start with, and eventually chamber enlargement and heart failure. More so, it also because it reaches to the heart in systole rather than diasystole, it compromises the flow to the coronaries as well. So this vicious circle starts. Risk factors starts the endothelial damage, which leads to atherosclerosis, that leads to arterial stiffness, and that vicious circle goes on and on. So we need to break that vicious circle. And we know from the studies that it starts way earlier than we have got the manifestation. So that's why hypertension is a silent killer, one of the risk factors in which leads to endothelial injury and arterial stiffness. More the risk factors you have, more the arterial stiffness you will get. So quickly going to bradykinin, it's one of the peptide which is produced in the body, and it has got receptor on the blood vessels that produces and once the receptors are activated, we produce nitric oxide, which causes vasodilatation. It's anticoagulant, it's an anti-inflammatory agent. Problem with the bradykinin is that half-life is just 30 seconds. On the other hand, the basics of RAS system is angiotensinogen. Angiotensinogen is converted to angiotensin 1 by renin. When kidney senses that your blood pressure is low or you're low in fluid, it produces renin, which converts angiotensinogen to angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by the angiotensin converting enzyme, and that leads to the formation of the angiotensin 2, which is a vasoconstrictor, which also stimulates the adrenal glands to produce aldosterone and pituitary to secrete more of an ADH, both of which then lead to fluid retention. It also increases the oxidative stress and endothelial dysfunction, hence leading to that formation of atherosclerosis, increasing the arterial stiffness as well. So keeping that concept in mind, we'll go to the mechanism of action of AC inhibitors, one of the pillars of blood pressure management. So AC inhibitors, not only, well, the AC inhibitors actually prevent the function of angiotensin converting enzyme. Hence, angiotensin 1 is not converted to angiotensin 2. Angiotensin 2 has got 3 receptors. The major one is AT1, which causes vasoconstriction. So we will prevent that vasoconstriction, and hence the anti-hypertensive effect of AC inhibitors will come in play. More so, it also stimulates AT2 and AT4 receptors, which will prevent endothelial apoptosis, meaning the deaths of the endothelial cell lining, and help in angiogenesis. One other important factor is that it also prevents the breakdown of bradykinin. And I already told you that bradykinin has got receptors on the vessels. Once they are activated, they produce nitric oxide, which causes vasodilatation, which has got anti-inflammatory and anti-thrombotic effects. So once the AC inhibitors are initiated, they increase the bradykinin in the body and they decrease the angiotensin 2. Hence, have got anti-hypertensive effects, but more so, they have got effects on angiogenesis and prevent endothelial apoptosis. So that extra effect needs to be kept in mind. While comparing the action of AC inhibitors to the angiotensin receptor blockers, only blocks the AT1 receptor activation. It has got no effect on bradykinin, and it has got no effect on AT2 and AT4 receptors. Hence, there is no endothelial apoptosis. Hence, there is no increase in bradykinin as well. Their anti-hypertensive effect is via the blockage of AT1 receptors, and the vasoconstrictive effect will be prevented, and hence the aldosterone production and the ADH production as well. More so, angiotensin 2 has got, and the blockage of that leads to the anti-inflammatory effects as well, and the decrease in the oxidative stress to the vessels. Okay, so that's the difference between the two. There is a study in which we looked into it. It is a sub-study of the Europa trial, in which they look at between the placebo and perindopril and the levels of angiotensin. And it's very understandable, as I explained the mechanism of action. After 1 year, the perindopril arm showed the decrease in the level of angiotensin 2 at 1 year, which was statistically significant, as well as rise in the bradykinin levels, more so decrease in the endothelial apoptosis. Hence, all that leads to the extra effect beyond the blood pressure control by the AC inhibitors. Among the same group of AC inhibitors, perindopril in vivo showed the maximum effect of that, which was statistically significant as compared to the rest of the AC inhibitors. And when we compared this with the ARBs, because ARB have got no effect on AT2 and AT4 receptors, the endothelial cell apoptosis is only seen with perindopril and not with the ARBs. Hence, this is the additive effect we have got with AC inhibitors. Now, looking at the evidence, we have got plenty of evidence for the AC inhibitors. I'm just going to quickly go through, and I'm wary of the time as well. The HOPE trial. It was a multi-center, randomized, double-blind, placebo-controlled trial. One arm, about 9,200 participants over the age of 55. They either have got diabetes and a risk factor, which is established for coronary artery disease, but no heart failure. And one arm have got ramipril versus placebo, while the other arm had vitamin E versus placebo. And only the effect was seen in the ramipril arm this showed 22% relative risk reduction, 22% relative risk reduction of cardiovascular deaths, MIs, and strokes. And this effect was beyond the control of hypertension. Likewise, in Europa trial, it was a randomized, double-blind, placebo-controlled, multi-center study. There were about more than 12,000 patients with stable coronary artery disease but no heart failure. On one arm, there was perindopril, on the other was the placebo, and they were followed up for about 4 years. And there was 20% relative risk reduction in the primary outcome, which was cardiovascular death and non-fatal MIs. Moving to another very prominent trial, which is the ADVANCE trial. Again, it was multi-center, more than 11,000 patients with type 2 diabetes at about 215 different centers in 20 different countries. And they looked at perindopril indapamide initially to start with for blood pressure control. And the primary outcome was that it reduces the relative risk for all-cause mortality by 14% and cardiovascular deaths by 18%. In the same trial, they added calcium channel blockers, and addition of calcium channel blocker in perindopril and indapamide result in further 28% reduction in death. So there was 28% relative reduction with perindopril indapamide amlodipine combination. So if I summarize the guidelines, which is ESH guidelines, or if you look at the AHA guidelines as well, the main antihypertensives are ACE inhibitors or ARBs, thiazide-like diuretics, long-acting calcium channel blockers, and beta blockers as well. There is indications of beta blockers, especially those who have got heart-related diseases. If we look at, and as I said, if your blood pressure is between 130 to 140, you can start with single antihypertensive. If your blood pressure is above 140 by 90, most of your patients require 2 antihypertensives. Please use it in a 1 pill to increase the compliance, and you will go up the ladder. So if we look into, so ACE inhibitors and ARBs from their antihypertensive point of view, almost equal. But if we look at beyond the antihypertensive effect, and this is one of the study published in JAMA in 2020, that actually it was a meta-analysis, and they combined 46 eligible clinical trials, and that led to about 250,000 total participants. And the results, and the important one I have highlighted, number one, each 10 millimeter mercury reduction in systolic blood pressure and 5 millimeter in diastolic blood pressure significantly associated with a lower risk of cardiovascular death, stroke, and overall cardiovascular events. So these medications are associated, once you control the blood pressure, you avoid cardiovascular deaths and all that. But importantly, they've noted that angiotensin converting enzyme inhibitors were reported to be the most effective in reducing the risk of myocardial infarction by about 28%. And the role and the use of diuretics were reported to be the most effective in reducing the revascularization, which is about 33%. So number one effect is that they're antihypertensives, but in ACE inhibitors, as I alluded to, their mechanism of action by increasing the level of bradykinin and eventually the nitric oxide, and effect on 82 and 84 receptors and decrease the endothelial apoptosis, there is an additional benefit regarding cardiovascular mortality, especially from myocardial infarction point of view. So we need to keep that in mind as we prescribe the antihypertensives to our patients. Moving on, the 2024 ESH guidelines about hypertension in CKD. Again, both ARBs and ACE inhibitors are wonderful medications. Number one, primarily because they control the blood pressure. Two, they decrease the proteinuria. And the evidence was more in favor of ACE inhibitors. Just keep in mind the down effect of the increased bradykinin, which we achieve with ACE inhibitors, is that we can have the cough and the angioedema. Although in my personal experience and from the literature as well, the cough is about 5%. Some literature says up to 20%, and angioedema is actually less than 1%. So I am wary of the time, so I'll be very quick. Quick 2 or 3 slides left. So among the AC inhibitors, perindopril is the most effective one from all-cause mortality effect point of view. We know the ESCOT trial, which compared the beta blocker thiazides with perindopril indapamide, definitely effective in controlling the blood pressure, more so from cardiovascular mortality point of view as well. So they actually have gone and followed up these patients up to 16 years, and they have noted 29% fewer stroke deaths. And in the same study, when the atorvastatin is added to control the cholesterol, they noted that there is 15% less cardiovascular death compared to placebo. Advanced trial does tell us that when we combine perindopril, indapamide, amlodipine, we get a relative reduction of 28%. That is beyond the blood pressure control. Most of these guidelines, if you look at, they will guide us or recommend that we use AC inhibitors or ARBs, thiazide-like diuretics, and long-acting calcium channel blockers. From the evidence and from the mechanism of action point of view, I think this combination of perindopril, indapamide, and amlodipine is far better because it gives you extra cardiovascular protection on top of blood pressure control. So my dear friends and colleagues, in conclusion, hypertension is a silent killer. Number one, it's the number one risk factor associated with the number one cause of death, which is cardiovascular. We know that it's a silent killer, and despite our efforts, we are still struggling to control the blood pressure in majority of our patients. Data suggests only 20% of our patients with hypertension have got control. The rest of the 40%, well, about 40% are undiagnosed, and the rest of the 40% have got poor control. And the reasons for that is the patients are unaware of that, poor compliance, but physician inertia is also a big factor. So we need three-dimensional blood pressure control. We need strong and rapid blood pressure reduction for 24 hours. And for that, the combination of amlodipine, perindopril, or perindopril, amlodipine with thiazide-like diuretic, which is indapamide, is one of the effective way to control the blood pressure. Thank you very much.
Thank you, Dr. Muhammad, for this excellent and very clear presentation. So we'll keep all questions and comments until the end of the third presentation. And you can register to the WeBook platform by scanning this QR code. Now it's time to move to the second presentation by Dr. Walid Al-Dahi, President of Kuwait Diabetes Society. He worked at Mubarak Al-Kabir Hospital, Jabriya, Kuwait. Dr. Al-Dahi will talk about diabetes and metabolic factors. Dr. Walid, you are on mute now. Can you unmute your the Zoom, please? Dr. Walid, we are not hearing. Yes.
Do you see my slide?
Yes, it's better now. Okay, thank you.
Okay. This far so I can do this. Yes. Is that okay?
Perfect, thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for your kind introduction. This is Dr. Walid Al-Dahi from Kuwait. It's my pleasure and honor to join my colleagues. And I'm also thanking Servier for involving me in this program tonight. So this is my disclaimer. So talking about diabetes and metabolic disease and medications that I can use to control our patients, we know that diabetes is one of the biggest global epidemic around the world. This is just to show you the amount of projections of increase in the prevalence of diabetes around the world. You can see the arrows is always going up throughout the world. If you look at in our area, in the GCC, for example, we are sitting on the top prevalence of the world, all of it. And Kuwait is in the top of the GCC, as you can see here, 25.5%. And the projections for Kuwaitis in the next 20 to 30 years is going to be very grimsy, as you can see here. So this is from the IDF, the total number of adults between 20 and 79 with diabetes in Kuwait. In 2000, it was 75.6 thousand, and we're expecting, nowadays we have around 9,000, and we're expecting to go 1.3 million. This is part of just a 4.5 to 5 million population in Kuwait. So this is a very serious disease and endemic. Now, we all know that diabetes actually is not just simple hyperglycemia. It is a very complex disease, and it involves many metabolic changes. If you put diabetes, obesity, metabolic syndrome all together, which we as physicians in endocrinology and many of our colleagues, they believe that these are on the same spectrum of the disease. So they are not separate, they are always together. And also hypertension is part of it, as my previous speaker elegantly explained it. So cardiovascular disease, coronary heart disease, CKD, thrombosis, gout, fatty liver, gallstones, infertility. Cancer is also increasing in patients with obesity and diabetes. There's lots of also obesity and diabetes can cause some associations with mechanical problem like sleep apnea, asthma, incontinence, knee arthritis, physical and functionality. And also, it also affects our mental status like depression and anxiety. So when you are dealing with diabetic patients, you're dealing with a full spectrum of diseases that involve many parts of the body. And that's why treating diabetic patients is not as easy as we can see. We know that diabetes-related complications that we are talking about actually consume lots of money throughout the world. So it's approximately 80% of the total diabetes expenditure goes for these complications. And medications is the cheapest thing to deal with diabetics. We always say that there's new medications that are expensive. They're not expensive compared to somebody who goes to the OR for diabetic foot, or going for a catheter, or going for something else in the hospital. So this is a very fallacious disease. When you look at prevalence of atherosclerotic cardiovascular disease in our area, we can see that it is also very high. This is from the PACT-MEA, which is we all involved in it in the Gulf, and some our colleagues from the MENA region. It shows that in our area also cardiovascular disease is higher. As I remember when I was when presenting first this, one of the cardiologists said that, for example, Kuwaitis, they do have the first MI at least 18 years younger than the European. So this is a very bad complication. Again, this is from PACT-MEA, and you can see here for obesity and cardiovascular disease, you can see here that the higher your BMI, the higher your level of cardiovascular disease. And this is basically a very well established fact. We know that diabetics who have cardiovascular disease or CKD, or just being a diabetic, they live less than the non-diabetic. So you can see here the non-diabetic on the top, comparing type 2, they have -6 years. type 2 and early CKD minus 9.1 years, and diabetes and stroke or MI minus 11 years. So people will die earlier when they have diabetes. And despite of all the available medications we have, and we're going to see from our guidelines, still we have diabetes remain the 9th major cause of global death. 26.9% patients type 2 diabetes have peripheral neuropathy, 18.9% have cardiovascular disease, and 21% of patients have kidney disease. So basically, we're still not doing very well in fighting this disease and its complication. So this is just a question for you to think about, and then I'll give you the answer. So according to the Diabetes Care Survey, diabetes management and complication in the Gulf countries, out of all diabetic patients receiving treatment in the Gulf, what is the percentage reaching optimal HbA1c? And I'm sure maybe you saw this before, so it's 24% only of diabetic achieving treatment and reaching HbA1c of less than 7, while only 13% of diabetic patients are reaching HbA1c less than 6.5. So we're still not doing very well. And put the fact in your mind, the fact that in the Gulf, we give our patient the treatment for free. So this is not a problem for us, and we're still not doing very well in terms of glycemic control. This is another cohort looking at the glycemic control in the Gulf, and also here including Egypt and Lebanon and Oman and Tunisia. And you can see here 17% have less than 7%, 7%, 32%, 8 to 9%, 24, and 27% more than 9. So majority of our patients are actually above 7%, and about 50% are less than, more than 8%. So most of the patients are actually out of control, unfortunately. Now, what are the causes of poor glycemic control and therapeutic inertia? The previous speaker alluded to inertia, and inertia is, I think, one of the cornerstones in the management of diabetes that will lead to such complication and such high rate of complication. You can see here the inertia could be by physicians, time and resources constraints, patients, sometimes injection-related factors, not accepting more medications, and healthcare system lack of proper care plan that's available in many countries, unfortunately. Some people with type 2 diabetes with having HbA1c more than 7 on one oral hypoglycemic agent, the mean time to intensification with an addition of another agent is 2.9, and insulin or injection is more than 7.2. So imagine 7.2 years. And for me, I give a lot of lectures for primary care physicians, and when they ask them about this, they always say that the patient don't like the injection, and then years goes by and visit after visit, and the patient end up having complications. 7 years is enough for a patient to develop micro and macrovascular complication, as you all know. So any delay in like a 1 year delay in treatment and intensification in people with type 2 diabetes with an HbA1c more than 7% associated with 67% increased risk of myocardial infarction, 64% increased risk of heart failure, and 51% increase in risk of stroke. So just 1 year delay. And imagine most of the patients, from previous slide, most of the people who need injectables, they will be delayed around 7.9 years, and oral around 3 years. So this is very significant. This goes on us as physicians, where we have to convince our patient and explain to them this data to show them that you're not only having just high blood sugar, because many people, they don't realize that blood sugar of 7.8 or 8 or 7.5 is bad for them. They said, "Oh, دكتور, يعني دعوة 7 ياري 10." That's all they say in our clinics. They said, "Look at my neighbor. He have a glucose of 10 and he's walking." So this is basically something. So this is a paper published by one of our colleagues, Ahmed Rashidi from Kingdom of Saudi Arabia, and he actually summarized, after studying this issue, factors associated with poor glycemic control in the GCC countries. And he put them in these points: low level of education, We still have many people, their general education is not high, longer duration of diabetes, poor compliance to diet and medication, poor attitude toward the disease, which, as we said, believes they think it's not a big disease, it's just a number, and poor self-management behavior, anxiety, depression, and renal impairment. These are the factors that he noticed from studying this issue. So this is something for us also to learn. Now, we know from important trials, the big trials in type 2 diabetes is the UK-BDS, as you all know. And in UK-BDS, we know that the importance of lowering glucose leading over a long time of treatment and early tight control leading to decrease in complications, like any diabetes-related endpoint, 21%. The maximum we get from vascular and microvascular disease, as you can see here, 37 and 43%. Fatal and non-fatal stroke, around 12%. Fatal and non-fatal MI, 14%. All-cause mortality and cataract is increased, and diabetic-related deaths all increased. So we know when you early control your patient, as in the UK-BDS, actually you lead to decrease in these complications. We also know it from following up these patients until from 97 to 21, we know that this reduction in mortality and cardiovascular disease, it's actually persistent after many years. So this is very, very reassuring that to tell our patient that if you control your disease early, you get the legacy effect of the control early in the disease. And that's what you see here in the box, the red box on the right. You can see any diabetes related endpoints, it's still significant. Myocardial function is still significant. Microvascular and all-cause mortality are still persistent despite the very long follow-up duration. And that's one of the longest duration in type 2 diabetes to manage patient early. We know that also when you look at micro and macrovascular disease, you can see that most of the trial, this is looking at all complications like non-fatal MI, microvascular disease, retinopathy, and nephropathy. We know that microvascular outcome and nephropathy were significant in terms of reduction, and non-fatal MI and retinopathy was a trend, but that also tell us when you actually treat these patients, you get an overall reduction of all kind of complications. So consequence of delaying glycemic control, that lead to increase in these complications, as you all see. Now, when you look at anti-diabetic medication, we have many classes, and we have preferred classes and we have less preferred classes based on evidence and based on the change in the guidelines. I'm sure you know all of this, you don't have to go through it, but we know that there are several classes that we are using to treat our diabetic patient. Some of them is now on top and some of them on bottom. So this is how the guidelines that we follow look like. So now the guidelines is encouraging us when you see a patient in your clinic is not to treat him as a number of glucose. You have to look at first, is he having a CKD, heart failure, or atherosclerotic cardiovascular disease? So we will segregate the patient in our mind, not like before. When I was in the fellowship back in Boston in 2000s, the ADA was telling us if the patient have high glucose, you start early insulinization. But now, because of the availability of evidence and medication that may alter the patient outcome, now we think about patient. Do they have CKD, heart failure, or atherosclerotic heart disease or not? So if they have, you will use SGLT2 and we know from SGLT2 inhibitors, these are the two major papers that came from the empiric trial and gamma CKD left.
Maybe there's a problem with Dr. Walid. We'll try to fix it now.
Dr. Raad, can we wait for like 1 minute for
Okay.
Dr. Walid to join back? He joined back already, Dr. Walid.
Okay. Dr. Walid, do you hear me?
Sorry, I was.
There was a problem, a connection, maybe.
Do you see my slides now?
Yes, very good.
Okay, so I was talking about GLP-1. I hope I was starting here. So when we talk about GLP-1, they work on several ways to actually control diabetes and actually improve the metabolic status of diabetics, like working on satiety, working on the muscle of the heart, working on the vessels, working on the kidney, on the fat cells, and also on the pancreas by glucose-dependent insulin secretion. And we know from trials, that is just to save time, I put for you several trials showing that they are actually having effective HbA1c reduction, and the primary outcome of a decreasing cardiovascular disease is actually proven, as we can see here from semaglutide studies. Again, this is a pooled data meta-analysis from many trials like SELECT, FLOW, STEP, HF, heart failure with preserved ejection fraction, and a STEP trial, and there is 31% reduction in cardiovascular death or worsening of heart failure. So these drugs are very favorable in terms of cardiovascular disease, heart failure, and second to SGLT2 inhibitors in terms of CKD. So this is something that we have to think about very seriously. But also the guideline, they kept giving you other options, like when you want to minimize hyperglycemia, you still can use DPP-4 inhibitor, SGLT2, TZDs, or sulfonylureas. Again, if you want to look for weight, and for patients who don't have cardiovascular disease or CKD, you can still prefer to use GLP-1 or SGLT2 inhibitor, and later you can use the other ones. But also, when you consider cost, and cost is one of the important factors that may actually alter your decision. In Kuwait, for example, for non-Kuwaitis, the drugs are not, for Kuwaitis are not for non-Kuwaitis, so they have to buy some medications for diabetes. If you look at the guidelines around the world, like an IDF guideline, they still kept drugs like metformin, sulfonylurea on top of your selection, because many parts of the world, they cannot afford having drugs like SGLT2 inhibitors. This is again some guidelines from our area. This is the Saudi guidelines, and you can see here all medications are put as an option, and also for patients who have certain diseases, you will get a certain option. Here's the Saudi guidelines. If anybody with atherosclerosis, GLP-1, SGL2, CKD, SGL2, GLP-1, cost, an issue, SU and TZD. In Kuwait, we don't have TZDs. Hypoglycemia problem, TZD, DPP-4, SGL2, and GLP. Obese or overweight, use GLP or SGL2. So this is again the United Arab Emirates guidelines. Again, they put all the classes to be used. As you can see here, if there is benefits on the left, you can see GLP-1 and SGL2. If there is certain benefit from that, that's cardiovascular disease and renal disease. But on the right, this is consider efficacy, hypoglycemia, impact on weight. You can use the other medications. And we all know that we have many patients in the spectrum of diabetes, very early and late, and not all of them. So one of the also bigger trials that's been published in type 2 diabetes, second to UKBDS, is the ADVANCE trial. So the ADVANCE trial, looking at randomization of 11,000 patients, looking at intensive glycemic based on glycoside versus standard of care. And you can see there was a significant reduction in the glycated hemoglobin using the intensive control. Also, when you look at combined major macrovascular and microvascular disease, it was in favor of gliclazide comparing to the standard control. When you compare sulfonylureas together, you can see, we know from the Accord, where they use 78% glimepiride and insulin and TZD 91%, you can see that there was increase in cardiovascular death. But in the Advance, where they use 91% diamacron, 40% insulin, 17% TZD, less TZD, 12% reduction in cardiovascular disease. So still you have options. This is a comparison between sulfonylurea, gliclazide to sitagliptin. And you can see here, when you compare sulfonylurea to sitagliptin, which is a very much used, standard used DPP-4 inhibitor, looking at, HbA1c, and secondary outcome looking at HbA1c in different levels, and hypoglycemia. So the trial was done over a long time. Just to show you, looking at durability and persistence, you can see that they both, gliclazide and sitagliptin, were doing the same in terms of, durability and persistent in terms of their effect. And this is also was surprising, because we think that, these medications, they work on a different ways on the body, but they still kept giving the same effect. When you look at hypoglycemia, we always think that hypoglycemia will be higher in gliclazide than sitagliptin, but it was not significant, although numerically it is a little bit higher. When you look at, Okay, so here looking at probability of HbA1c less than 6.5, you can get more probability by using sulfonylurea compared to DPP-4 inhibitor. So 35% more likely to reach target with HbA1c less than 7. Again, when you compare different sulfonylureas, we know that we have a very long history with the sulfonylureas since the 50s, and have many types of sulfonylureas, but they are not all in the same basket. And this is, you can see here on the top left by Dr. Bunayef al-Sifri, our colleague from Saudi Arabia, looking at percentage of hypoglycemia. You can see here that gliclazide compared to sitagliptin, they look the same compared to other sulfonylurea. And if you look down, you can see that the number of years, if you want to use sulfonylurea to start insulin, you may delay the use of insulin by using gliclazide by 14.5% comparing to glibenclamide, the older form, which by around different 6.5%. So this is a very tolerable drug, and it may help your patient in some situations. What about comparing different sulfonylureas with the effect on intensive glucose control than weight? You can see that the weight in Advanced trial, which is the biggest trial after UKBDS and the type 2 diabetes, was neutral actually, and it was not surprisingly that we expected to be high, but it actually was neutral. You can see from UKBDS, where they used insulin too, they have more, around 1.7% comparing to the other Accord and VADT, where they used the older form of sulfonylurea. Again, effect on CKD, and this is the major results from the Advanced trial: new onset microalbuminuria, new or worsening, new onset of microalbuminuria, and end-stage renal disease. They all reduced by significant percentage. You can see risk of end-stage renal disease by 65%. But remember, these are patients who received very early control of their diabetes using sulfonylurea. So early control is the focus of the prevention. So take-home message, type 2 diabetes is a progressive disease that required multiple therapeutic approach. Early control is crucially important. Glycemic control was and still an important aspect of managing type 2 diabetes. SGLT2 inhibitor and GLP-1 are the focus of treatment in diabetic with heart disease and kidney disease, and SFU are still sulfonylureas are still effective anti-diabetic agents, especially the ones with a strong evidence safety regarding weight and hypoglycemia and efficacy. It should be considered as an option in our management. Thank you very much.
Okay, thank you. Thank you very much, Dr. Walid, for this very informative presentation about diabetes. And I want to remember you also, you can register to the WeBook platform by scanning the QR code here. And this is a CME credit meeting, and you will receive your certificate very, very soon. And now we move to the third and the final presentation, treating multi-morbidity with Dr. Fahad Al-Kindi, Head of Cardiology Unit and Senior Consultant and Interventional and Structural Cardiology at University Medical City, Sultan Qaboos University Hospital at Muscat, Oman. Dr. Fahad.
Good evening, everyone. Thank you for joining us in this webinar. It's an honor to present alongside with my distinguished colleagues. My talk today is going to be about the multi-morbidity, and I'm going to talk a bit about microvascular dysfunction. I'm not sure if my slides are moving. I'm trying to move my slides.
You have control, Dr. Fahd.
The first slide is not moving. It's kind of stuck. Do I have the control on the slides?
You have control now, Dr. Fahd. Please try again.
It's not. Okay, now it's moving. I would like also to thank Survey for organizing this webinar. So, so talking about multi-morbidity, as this slide actually was shown by Dr. Raed at the beginning of the webinar, showing the prevalence of multi-morbidity worldwide. As you can see in this slide, the overall global prevalence about 37%, which means that 1/3 of population in this world is having multi-morbidities. And if you look at the map here, you can see the highest prevalence is in South America, around 45%. But even in our region, the prevalence of multi-morbidity is very alarming based on this study. And if you look at the over the years, over the last 13 years, the multi-morbidity has significantly increased. And this rise is not explained only by the age, but of course there is definitely other reason for this rise of multi-morbidity. If you look at this slide, you can see that the prevalence is high not only in elderly, but it's actually across all age group. And if you think about your practice, you can tell that from the average age of patients that coming to your hospital. For me as an interventionist, we are actually very surprised in the last years that how adult are the patients that we are receiving every day, having coronary artery disease and of course other multi morbidities. I'm having difficulty here moving the slides. That's why, I find it a bit difficult to, be smooth in the flow. It takes a time to move from one slide to another slide. Of course, if you look at this study in US, this cross-section study that looking at the cost on the health system, it is very clearly showing that the cost is a very dramatic burden on the health sector with the increased number of the comorbidities. And that, of course, also showing here in the slides, not only the cost, also the number of the comorbidities that is adult patients having. In this study, they found that the average age of the patients who have more than 5 comorbidities is around 53 years old. So what is the difference between comorbidity and multi-morbidities? Actually, they are, although the term look like similar, but they are not the same. While the both focus on the occurrence of multiple chronic condition, comorbidity refers to the combined effect of additional condition and reference to an index condition. Like a patient who has a heart failure, we usually focus on the heart failure while he's having other comorbids like diabetes and hypertension. And this actually result into fragmented treatment of the patients. In contrast to multimorbidity, it does not routinely place one single condition rather than placing the patient in the center of the care, which will lead eventually to the giving care to the every comorbid that this patient is having. And that's why, in order to improve the continuity of the care, we have to shift from disease-centered care to a patient-centered care. And that has to be done, through certain steps by planning. And first, you identify who are the higher risk patients, which means that those patients who have multiple comorbidities, and then you plan a time for the assessment. And actually, also you can plan who's supposed to see the patient first, and based on the prioritization of the patient himself, and then of course you have to make a full plan regarding the review of the patient and promote a relationship between the practitioners and the caregivers. Now let's switch the gears and go through one case so that we can discuss this case and see how we can tailor the management of this case based on the patient himself. So this is a 74-year-old female who had presented to the emergency department with a chest pain and exertional dyspnea. Actually, she suffered from these symptoms for the last 6 months, and her symptoms got worse recently. Even she's complaining of the rest, even chest pain, even at rest. So this patient, past medical history, she's hypertensive, she's diabetic, and for the last 10 years, she's also dyslipidemic. She's obese, so you can see this is the typical profile of patients that we see in our area. She had an echo 8 months back, and she was found to have low ejection fraction of 35%. Her vitals, her heart rate is 80 beats per minute, with a blood pressure of 140 to 90. And of course, as Dr. Mohammed presented in his first presentation, this is considered already at the at the level of the stage 2 hypertension. She was not in failure clinically. Her ECG, as you can see here, showing sinus rhythm, but there is evidence of LVH. The chest X-ray is showing cardiomegaly, enlarged heart, which also explains the echo finding with the low ejection fraction. So most likely the heart is dilated, and her pro-BNP was found to be high, 720, with a mild renal impairment. So based on this, echo was also done during this admission, and it showed the low ejection fraction of 35% as it was before. So based on the presentation, which is typical chest symptoms, which is anginal symptoms, along with the exertional shortness of breath and low ejection fraction, patient was decided to go for cath lab to screen the coronaries. And her coronary angiogram showed normal coronaries angiographically. Hence, she was discharged on the 4 pillars of the heart failure with the reduced ejection fraction that we know: sacubitril, bisoprolol, spironolactone, furosemide, and dabigatran. So we have to, despite all the medication that we know in HFrEF, which are the 4 pillars, based on the landmark trials that showed the benefit of this medication in terms of both survival and rehospitalization, there is still, considerable amount of patients with the residual risk that they are still having symptoms despite giving them all the 4 pillars of the medication, and even despite the optimization of the dose of anti-failure medication. So this patient, he was, as I said, discharged on those medication. However, he was brought again for a follow-up in the clinic. Patient blood pressure improved. However, her symptoms were still the same. She was still having chest pain, and she was still having exertional shortness of breath. Repeated echo again revealed the same ejection fraction without any improvement. So what should we do next for this patient? Before discussing the patient and the further management, I would like to talk about the microvascular dysfunction and its role in the patient's symptoms. So ischemia is not always caused by the obstructive coronary artery disease. Coronary microvascular dysfunction can impair myocardial perfusion despite normal coronary angiogram, like in this patient. And if you look at the this diagram, you can see that the epicardial mechanism of ischemia is, as we know, it can be either structural or functional mechanism. Of course, structural mechanism we can identify by coronary angiogram. However, functional mechanism like epicardial spasm, it's very difficult to identify it through coronary angiogram. This is regarding epicardial mechanism. And also, there is microvascular mechanism of ischemia, which can be also due to either functional mechanism due to impaired vasodilation or enhanced vasoconstriction. that is secondary to endothelial dysfunction. And this endothelial dysfunction, one of the major reasons for it is the comorbidities like hypertension and diabetes and obesity. And of course, microvascular dysfunction also can be of a structural mechanism like abnormal vascular remodeling secondary to LVH in hypertension, or because of extensive vascular compression. And this, of course, can lead to symptoms similar to what our patients presented. So, and that's what is called INOCA, which is ischemia with non-obstructive coronary artery disease, which is historically actually under-recognized even by us as cardiologists. And because of several reasons, one of them is the misconception about normal coronary arteries. Once we see that the arteries are normal in the coronary angiogram, we think that there is no coronary dysfunction, and we don't think about the microvascular dysfunction. So there is underappreciation of microvascular dysfunction, and there is also lack of awareness among clinicians. And of course, because of that, even in the guidelines, there is no stress or emphasis on the microvascular dysfunction like what we see in the epicardial disease. So why we should not ignore INOCA? Because the prevalence is high, up to 50% of patients who have normal coronary angiogram, there still remains to have a chest pain. And that actually has a very bad impact on the quality of life and the prognosis of the patient. And if you look at the coronary circulation, actually what we see is the tip of the iceberg, as I say. So the coronary circulation, the microcirculation is even bigger than the epicardial circulation. The arteries which are less than 200 microns, which are we don't see by the eyeballing during angiogram, they are representing more than 50% of the circulation. That's why in the European guidelines in 2024, they actually have replaced the definition of stable coronary artery disease into chronic coronary syndrome, because it's not just one entity, it's a spectrum of disease that where the patient can present in different forms, like our patient with LV dysfunction or stress-induced angina, or positive stress test with normal coronary angiogram. So they can present in different way. If we don't really think about microvascular dysfunction, these patients can be missed very easily. So if we ask this question again back to our patient, she had the 4 pillars, full dose, normal coronary angiogram by cath. Her heart rate is 80. Blood pressure now is much better, 115/70, with mild CKD. What next would you like to do? You can submit your answer. So the majority answered that add ivabradine, which I agree with that, and we'll see why. So it's very important when we deal with the patients that we don't look at them the same. We have to tailor the treatment according to the patient's profile. It's very important to look at the heart rate of the patients, the blood pressure of the patients, and to look at the rhythm of the patient. Is he on AFib or on sinus rhythm? And of course, to look at the other comorbidities and tailor the management according to that. Again, the slide is not moving here. So this is very nice table. It can guide you to tailor your medical therapy according to the patient's profile. So if we look at our patient, he has blood pressure which is slightly in the lower side, but the heart rate was still above 70. It was 80. So according to this table, this patient should get his heart rate controlled, and ivabradine is the best option here since his blood pressure on the lower side. And according to many studies, like the atmosphere study and paradigm trial, it has clearly showed that the heart rate is not just a vital signs that we regularly do. Actually, it's a risk factor in which we have to control very well, because it's a very strong predictor of the cardiovascular event. The lower the heart rate you get the patient, is the lower the cardiovascular event. So according to the guidelines, the recommendation is to get the heart rate is below 70. And ivabradine is one of the medication that it is very often forgotten by us. Of course, we have to start the patient on beta blockers and maximize the dose of beta blockers. But many patients, they cannot tolerate the beta blockers because of the hypotension, or they reach the maximum dose of beta blocker without reaching the target heart rate. That's why ivabradine is one of the medication that has shown a major outcome benefit, especially in patients with heart failure and reduced ejection fraction. And you can see the impact of ivabradine in this SHIFT trial, not only on cardiovascular mortality, it's also in rehospitalization and overall mortality. And it has shown that it is a very safe and effective medication across all spectrum of the blood pressure. Even if the blood pressure of the patient is a borderline, the impact on the heart rate is strong and with a very minimal effect on the blood pressure. That's why in the ESC guidelines 2024, ivabradine has been upgraded to 2A, especially in patients with low ejection fraction of less than 40%. So if we go back to our patients, this patient was started on ivabradine, which is it gives the hemodynamic effect by increasing the oxygen supply and reducing the oxygen demand. We should also not forget that the myocardial ischemia is also because of a mismatch between the energy demand versus energy supply. In which a medication like trimetazidine, which enhance the myocytes energy by shifting the cardiac energy metabolism from fatty acid to glucose oxidation, in which it will require less oxygen use to produce an ATP, is very effective in such scenario. And this has been shown that adding on trimetazidine effectively reduce the number of anginal attacks and also reduce the need for nitrate use, in which many patients also they suffer from side effects like headaches and also hypotension. So according to the guidelines, now, as I mentioned before, patients with CCS and heart failure with the reduced ejection fraction, we need to use the anti-anginal medication starting with the beta blockers. However, if the heart rate is still above 70, then you have to consider ivabradine as a class 2A. And if the patient is still symptomatic despite low heart rate, then you can add the trimetazidine as an anti-anginal medication. So our patient was started on ivabradine 5 mg BID plus trimetazidine 35 mg twice daily. And this dose was up titrated after 15 days. And in his last visit, his symptoms was, improved significantly from class 3 to class 1. And with the rest of the anti-failure medication with a heart rate of 75 per minute. Still slides on. Still struggling moving the slides here. So 6 months after anti-failure medication and anti-ischemic medication, repeated echo showed improvement of the ejection fraction with improvement of the clinical symptoms of the patient. So in a summary, heart failure and angina is a tricky association. Sometimes we need to tackle both. And of course, the comorbidities are far more common than we think. And we always forget to control the heart rate according to the recommendation, less than 70 per minute. And if the patient is still having symptoms, then we have alternatives like ivabradine and trimetazidine that might be considered, especially in this combination of heart failure with angina. Thank you very much.
Thank you very much, Dr. Fahd, for this very practical presentation. And I will start the discussion and question for you. Do you consider sometime in your practice treating patients who come to your clinic with inappropriate sinus tachycardia, symptomatic patient due to stress, to anxiety or obesity? Do you consider sometime treating those patients with ivabradine without any cardiac pathology?
Thank you very much. It's a very interesting question. Actually, this is a very common scenario. We see that very often, especially in young ladies. They have it's very common to see them with these symptoms and diagnosis of inappropriate sinus tachycardia. And practically, I have used it because in our region, the blood pressure, the average blood pressure in women is in the lower side. And many of those patients, actually, they come to us and we have challenges to treat them with the beta blockers because of the borderline blood pressure, and they respond to ivabradine in that scenario, and I have used it, and it is effective, especially if the palpitation is because of the stress induced. Yes.
And how many times you use it, for a long time or for a short period?
It depends, according to the stressor. I have used it many often in medical students, actually, because during their exams, and it works very nicely for them. But some patients, they have a chronic stress, a chronic anxiety, in which you have to put them on this medication, for certain time, according to that stress. Yeah.
Thank you, Dr. Fahad. Maybe we'll come back to you for other question. My question now to Dr. Muhammad. Simple question: ACE or ARB for a naive patient who had hypertension. When do you choose ACE? When do you choose ARB as first-line therapy for hypertension? And what factors influence your choice?
As per the guideline, you can choose
Okay.
between AC inhibitors and ARBs. When to start is as per the new AHA guidelines. If someone has got blood pressure above 140/90, you need to start antihypertensive. And most of such patient needs double antihypertensives in a single pill. While if your blood pressure is more than 130/80 with established cardiovascular risk, then you will start. If they have got risk factors, which gives you a high risk, then you will start the medications at threshold of 130/80 and above. And those patients who have got no risk factors, but their blood pressure persistently stay above 130/80, then you will give them lifestyle modifications for 3 to 6 months. If their blood pressure is still high, you will start the medications. And in my practice, keeping in mind that acute medic and I do stroke a lot, I think we need to treat the patients with high blood pressure. Choosing between AC inhibitors and ARBs, if we look at their antihypertensive effect, I think both are equal. But as my title was beyond the blood pressure control, if we look at that, and there is a lot of evidence based on, as I alluded to, the physiology and the pathology, the AC inhibitors have got added effect on increasing the bradykinin and the 82 and 84 receptor effect, which leads to endothelial apoptosis. And recently published data in JAMA, where they looked at, you combined about 46 trials and more than 250,000 patients. If my patient have got a risk factors for cardiovascular disease, I will go definitely with the ACE inhibitors to start with. I know that the cough, but cough usually happens in less than 1 or 2% of the patients. Most of the time it settles down. If it doesn't settle down, then yes, we will go for ARBs.
Thank you. There's one question about cough from the audience. Do you
Combination
think
with
that
amlodipine, they asked whether it reduces the cough or not. So
yeah.
if we look at the evidence, there is no strong evidence in favor of that. There is one trial published many years ago. They said that if you add amlodipine to perindopril, it decreases the incidence of cough. But with all honesty, no, there is no strong evidence. But we have to again keep in mind the positive effect of bradykinin on the production of nitric oxide and vasodilatation and anti-inflammatory and anti-thrombotic effect. So my suggestion will be, if the patient is complaining of cough, give them some time. If it is intractable and they keep coming back, yes, we need to switch them to ARBs.
Thank you very much. Dr. Wali, thank you again for this excellent presentation. And we have a question from audience about therapeutic inertia. Why do we have this number of therapeutic inertia? And how can clinician inertia treatment early? How can manage this inertia?
Now, inertia is one of the biggest issue in not only in our area, it's all over the world. I remember there was one trial looked at primary care physicians with regard to dyslipidemia. That's maybe 30 years ago when I was doing my fellowship, before my fellowship. They went to the doctors, they asked them about the lipid guidelines at that time, and everybody, more than 95%, they know the guidelines. When they opened the file of the doctors, they saw that the patient comes and goes and nobody actually applying the guideline less than 20%. So the problem with the inertia is at different levels. As the paper I showed you from Dr. Rashidi from Kingdom Saudi Arabia, he actually studied this and eloquently put these points that I shared. Most of the problem is that the level of care that's been given to our patient is very scattered. For example, in Kuwait, we have many doctors who are general practitioners, and they see many of the patients. And general practitioners are basically MDs with no further training. The second level is going to be primary care physicians, which is family doctor, proper trained family doctors who do much better. And then you go for internal medicine, and then you go for subspecialty like endocrine and cardiology. So for us, we have no problem. The inertia always in the primary care. And the reason is for two reasons. One of them is the patient don't trust primary care physician to make a decision that he said, okay, you want to take Lipitor 40 milligram? Oh no, send me to cardiologist. That's too much. If you want to start insulin, please send me to the hospital. And this is because of the accumulative level of GPs that are available down in the first liners who see the patient. So trust of the doctor is one of the important things. The second thing is the doctors themselves, there are lots of hesitance in terms of giving more medications or advancing in medications. We see this a lot. We see patients who are uncontrolled diabetes, dyslipidemia, hypertension. They come to us with complication, and we see that their number of medications is not escalated properly over the last 5 years before they come to us. So I think it's a primary care is the focus of inertia. That's at least in Kuwait. I don't know about the other countries, and they are improving. The more we have graduates from family doctor program, the better we have in terms. Now in Kuwait, we have SGLT2 inhibitors available in primary care. We have GLP-1 available in primary care. We have insulin available in primary care. So primary care physician is basically doing what the endocrinologists do, but not all over Kuwait.
Okay, thank you for this clear answer. And I have one question from the audience for you also, Dr. Walid. The recent guidelines are favoring for GLP-1, and where is the place in 2026 now for insulin, for basal insulin? We know insulin that is very effective. It can reduce the HbA1c for 2.5%. When do you use in practice the insulin, the basal insulin?
Yes, so basal insulin is something that is available now for many years. We know how to deal with it. We trust it. It gives, as you said, it gives your control quickly, but it's still, according to the guidelines, the mind of the guidelines nowadays is not to go for a specific drug. You go for what the patient needs and situation. So if my patient is basically having CKD, heart failure, or cardiovascular disease, the drug of choice is going to be GLP-1s and SGLT2 inhibitors. Now, insulin are always there going to be for patients who have acute elevation of glucose with catabolic state. Insulin will be the best, even for short term. And it's been shown many times in many trials, big and small, that if you use insulin early in type 2 diabetes, you actually give the patient a chance to be on oral medication later, and stopping the insulin is much higher. So we do use insulin for patients who come with very, very severe hyperglycemia with catabolic state, or somebody who is actually admitted with hyperglycemia. We prefer to use insulin. But nowadays, with the availability of SGLT2 inhibitor, the GLP-1, and the other oral medications, insulin is delayed. So nowadays we use insulin if we want to use a cheap medication, for example, of somebody who have not very well controlled, or somebody who don't have any complication and his glucose is high. Insulin will be safe.
Okay, great. Thank you, Dr. Walid, again. I have a question for Dr. Fahad. Dr. Fahad, in your patient, you presented, you used ivabradine. Do you have any indication when to combine ivabradine and trimetazidine in this kind of patient? Where is the place of trimetazidine in your patient? Is there any place in addition to ivabradine?
Yes. So, and the combination is because the patient has combined heart failure with chronic coronary syndrome. So this patient, when she presented, she has ejection fraction of 35%. Despite the 4 pillars of anti-failure medication, she continued to come as a follow-up with the exertional chest pain. And that's actually the main reason why I combine the two medication together. Ivabradine on top of beta blockers to get her on to the target heart rate, which is less than 70 per minute, which is according to the recommendation in both heart failure and chronic coronary syndrome. And trimetazidine is a metabolic agent that have different mechanism or as an anti-anginal medication compared to the ivabradine by energy metabolism from the shifting the energy from the fatty to the glucose, and with that many patients they feel much better in terms of chest pain.
Okay.
Yeah.
Very good. Thank you. Thank you very much. Finally, I would like to thank all distinguished speakers, the organizing committee, and all participant audience for this valuable contribution. And we hope for peace, stability, and security in our region. Thank you very much, and good night.
Thank you, everybody. Thank you.